Alright, hi everybody. This is my presentation on spinal cord injury C7. A lot of this will be review, but hopefully it's not super boring. So first off, my patient presentation. My patient is a 36-year-old female with a complete C7 spinal cord injury that she sustained from a motor vehicle accident. She presents with a few different things. She has orthostatic hypotension. She has autonomic dysreflexia, thermal regulation issues. She has urinary incontinence and sometimes uses intermittent catheterization. She has no reflex integrity below C7. She also has no sensory or motor below the level of C7 as well. She has a slightly impaired cough. She has spastic flexor tone of the fingers. And she definitely is suffering from depression at the moment as well. Our goals are pretty simple. First off, the short-term goals. She would like to be able to eat independently with the use of an AD. She would also like to wash independently her upper extremity with the use of an AD. She wants to perform 2 to 3 bed mobility actions without assistance. She would like to perform a wheelchair transfer independently, and she would like to have full postural control in sitting. For her long-term goals, and I hope you guys can see this, she would like to wash independently with AD using an AD her upper and lower extremities. She'd like to reach independence with intermittent self-catheterization without assistance. She'd like to perform all bed mobility without assistance, and she'd like to be independent with manual wheelchair mobility greater than 100 meters indoors and outdoors. So now we're going to go over the neurological condition and disease. So with spinal cord injuries, the level of the injury will indicate what deficits the person will have, and also it depends on if it's incomplete or complete. You have the neurological level, the motor level, and the sensory level, and those 3 different levels just basically mean the most caudal level of integration that they have. So if we're talking neurological level, it's the lowest level that you'll have any kind of neurological involvement. Same thing with sensory and motor, at the lowest level that you have any innervation. So spinal cord C7 will present as a tetraplegia. You lose function below the spinal segment of C7, obviously. You do have an intact diaphragm, so that's really good with spinal cord injuries because she'll be able to breathe. However, she has lost some innervation of accessory muscles, so she will have an impaired cough, and we'll talk about that when we get to the rehabilitation stage. One of the main things that's really important about C7 injuries is that they still have elbow extension, which is really important when it comes to any kind of transfers, and of course pressure relief to prevent any pressure ulcers. Also with spinal cord injuries, they may present with other cord signs or symptoms, such as anterior cord disease. That's really common with incomplete injuries in the cervical region. And diagnosis of the completeness of the injury is done using the ASIA scale, although I believe I misspelled it on here. So obviously my patient is incomplete, so she scores a level of A, but here I have the rest of the scores for us that I think we all know for the last test we took. Clinical syndromes will also be diagnosed when using the scale, and I think I have it on my next slide. Yep. I know this is really familiar, but this is actually what they use, and they will mark on here exactly what degree of innervation they have, manual muscle testing or sensory testing, and then there's a second page to this where it will go over other cord syndromes. So signs and symptoms. All signs and symptoms are dependent on the level and the presentation itself. So with her, sensory and motor loss is obviously lost. Sensory and motor are lost below C7, and she's going to have autonomic dysreflexia. She does have a spastic hypertonia, and she will have cardiovascular impairments, temperature control, pulmonary impairment, and bowel and bladder dysfunction. Plan of care for this patient. There's a couple different stages of rehabilitation, especially when it comes to the injuries that are sustained. So there's going to be an early intervention, which is basically kind of what I base the short-term goals on. But you'll want to work on breathing exercises right off the bat because of the loss of accessory muscles with breathing. So you'll want to teach them cough techniques, how to be able to produce a productive cough. You'll want to educate them in rehab about skin checks and pressure relief and how important that is and what can happen if they don't pay attention to that. You'll also want to do passive range of motion of all the joints, especially the lower joints, because contractures easily develop during those stages. It's especially important for you to gain good range of motion when it comes to the hamstrings. Make sure they're very flexible, because for these patients do any kind of transfers or bed mobility, they need to be able to do long sitting. So making sure that you have really good range when it comes to hamstrings is definitely important. And you actually want to avoid stretching of their spastic fingers, because they get a kind of tendinosis. So this actually helps with grasp, because they don't have their finger extensors or flexors, but they'll be able to grasp objects with that kind of hand. And you also don't want to stretch the trunk extensors. It's actually recommended that they have tighter trunk extensors, because that will help with their postural control and sitting. Later stages of rehabilitation, those are going to be more geared towards becoming independent with ADLs. So normally outpatient or inpatient at this stage. Once medically stable, they'll work on long sitting balance, they'll work on high sit balance, they'll work on all bed mobility and transfers to different surfaces, transfers in and out of the wheelchair to the bed, to the shower, to the toilet. Upper body strengthening is really important, especially since they do have extension. So triceps for transfers and repositioning, and then postural stability for sure, because they're not going to have as many trunk musculature to help them stay up. So postural stability is used in long sitting, short sitting, and wheelchair stance. You can use rhythmic stabilization and alternating isometrics to help with that, gaining stability. And those are my references. Apparently I'm done. Thank you.